this time. Welcome, everyone. It's a real pleasure to be here today, and I think this is meant for the broad HSI-TP community, and so we welcome people from whichever aspect of the broad team that you're joining us from now. I am Walter Wojcik, and I co-lead the um, mentorship stream. And pleased to do that alongside Shelley, who's here as well. And we have, we're kind of participating and supporting workshops related to the learning health system. So we've done a few of these now, and particularly in our mindset, we have the Learning Health System Action Framework, which has been published and is receiving a little bit of adoption in Canada and some support. So I'll recommend that as background reading if you haven't seen it yet. It's in Social Science and Medicine, one of their subjournals, Health Systems, I think it is. And so today, one of the essential gears in there, like so we have population health, evidence, co-design, and then implementation. And so today we have who I think are leading thinkers in Canada and in the world on implementation within this learning health system context. So Christine Cassidy and Mari Somerville are here with us today to lead us through our program. And I'll just say that Mari and they represent academics and implement and like health systems respectively. So Mari Somerville is a senior policy analyst within primary health care network at Nova Scotia Health. She was an impact postdoctoral fellow at Dalhousie and IWK Health, where they've really taken a big step forward in learning health systems. And now she is supporting optimization of integrated chronic disease management models across Nova Scotia. Christine Cassidy is associate professor in the School of Nursing at Dalhousie and a clinician scientist at IWK. And she also completed an impact postdoctoral fellowship at IWK with the University of Ottawa. And she's current academic supervisor with the program and has been really working from the academic side to support all of this. So I think we have excellent representation of exactly what HSITP is all about. And I will turn it over, I think, without further ado. Is that right? Any other intros or welcomes? All right, turn it right over to Mari and Christine. Thank you very much. Welcome.
Thanks so much, Walter, for the warm welcome. And hi, everybody. I will get us started by sharing our slides. Just looking for a heads up to make sure everyone can see those. Great.
Perfect.
Thanks. Okay, so Mari and I are excited to be here today to generate some discussion on how we can use implementation science principles to think about implementing learning health systems. And so Walter has already introduced us. I'm Christine, and Mari's joining me. So I'd like to acknowledge that Mari and I both live and work here in Mi'kma'ki, which is the unceded territory of the Mi'kmaq people, and it's also land where African Nova Scotian people have lived for over 400 years. And for me, I'm trying to take this time through land acknowledgements to really reflect on my own research practices that focuses a lot on knowledge mobilization, knowledge translation, implementation science, and learning health systems. And what do I think of when I hear the word knowledge and learning? Oftentimes, myself included, I really only think about research evidence and, more of my academic ways of learning about research evidence. But I think it's really important to acknowledge and reflect on the different types of knowledge, the different ways of knowing, and how that's mobilized and implemented within learning health systems. So it's something I'm trying to reflect on, and I encourage you to do this as well throughout this workshop. Our aim for today is to focus on 4 different learning objectives through this workshop. So we want to identify common implementation strategies that are used to operationalize learning health systems. We want to discuss as a group and recognize the gaps in learning health system development, implementation, and evaluation. We will be spending some time differentiating between impact outcomes and implementation outcomes, and then hoping that each of you will be able to apply some of these learning health system implementation science principles to your own embedded health system contexts. So the workshop plan is broken down into three parts. Mari and I will start and share some initial slides and content on learning health systems and implementation science. Building on that content, we have an interactive 30-minute breakout session. And then the plan for part three is to come back as a group and reflect and discuss on that activity. So to start off, and let's get us all on the same page. Many different iterations of this definition of learning health system, but to kick things off, we're defining a learning health system as a healthcare system in which clinical and care-related data are systematically integrated to really catalyze that discovery and implementation of new knowledge for the benefit of patients, community, and the organization through improved outcomes. Based on much of the foundational work on learning health systems, there have been many models and frameworks developed to encompass the different components of a learning health system. But at the crux of most of these models is this continuous cycle of practice producing data, which then leads to evidence and is incorporated with ideally external research evidence. And then this is put back into practice and the cycle continues. Building on these models and frameworks, other leaders in the field have really broken down this concept of learning health system and the different components of an LHS. So, for example, Dr. John Levis and colleagues from McMaster outline four core components of a learning health system, being data and evidence-driven, patient-centered, system-supported, as well as culture and competencies enabled. And that's aligns with 7 different key characteristics of a learning health system. And more recently, as Walter had mentioned in his introduction, the Learning Health System Action Framework and the LHS engine was developed with Walter and colleagues at Trillium Health and the Institute for Better Health, who are really leading this particular workshop series. And so, as Walter mentioned, each workshop is going through a different gear of the LHS engine. I believe in the chat, there's a link to the YouTube video from the previous presentation, which was on the co-design gear, but we're focusing today more on the implementation gear. So despite the availability of these learning health system models and frameworks, a question that still remained within our research team and partnership team was, how do we operationalize these models and frameworks in practice? And what does this look like in the real world? We wanted to explore this idea by drawing on the field of implementation science to support learning health system transformation. So just briefly, what is implementation science? It's a field of scientific inquiry, the study of methods used to promote that systematic uptake of research findings and other evidence-based practices. And as this definition outlines, the goal is to implement that into routine practice with the goal of improving the effectiveness of health services. I particularly like this breakdown of implementation science that was first described by Dr. Jeffrey Curran from the University of Arkansas that relates the concepts of implementation science back to the thing. So the intervention or the innovation, the practice change, that is the thing that you're trying to implement. And in more traditional academic training, I think we're really good at understanding effectiveness research. So looking at whether the thing, the intervention, worked or not. Did it actually improve patient outcomes? Did it improve health system outcomes? Implementation science really comes in with these final 3 buckets. So implementation science research looks at how best do we help people and places to do the thing, to use the intervention. Implementation science also focuses on those strategies, and that's all the stuff that we do to help people or places to do the thing. And it also includes implementation outcomes. So these are outcomes that describe how much and how well are people and places doing the thing or using the intervention. So my next few slides are just going to unpack these buckets in a little bit more detail as a bit of a precursor to some of these implementation science principles, keeping in mind that I'm aware some of you might already be familiar with this, and others this might be really new to you. So keep that in mind for the next few slides. So, a key component of implementation science is this focus on exploring determinants to implementation. So, this paper from Ali and colleagues from 2023 showed that a pre-implementation assessment of barriers and facilitators leads to more successful implementation of evidence-based programs. So, really important to understand those determinants, and that's where determinant frameworks come in. So, they help us to understand and or explain influences on implementation by specifying the types of factors that act as barriers and or enablers to implementation. When we take the time to identify barriers and facilitators to implementing the thing or the intervention, we then have a better understanding of the behavioral and the contextual factors of implementation. So, what's going to help or what's going to hinder our implementation efforts? There are many different theories, models, and frameworks that support this approach. I have two mentioned here, the Consolidated Framework for Implementation Research, as well as the COMBI model of behavior and how it's combined with the Theoretical Domains Framework. So again, two determinant frameworks that offer a range of factors, determinants that might influence implementation. Once you have a better sense of what those facilitators and barriers to implementing your thing, your intervention would be, we can start to think about what strategies should we actually be using to implement. And so, of course, there are more frameworks and taxonomies to help with this. The ERIC taxonomy, the bottom left here, is a compilation of 73 different implementation strategies to support that work, as well as the behavior change wheel on the right-hand side includes 9 different intervention functions or kind of categories or buckets of implementation strategies. Lots of work in the field of implementation science has been done on mapping these strategies onto the determinant frameworks that I mentioned in my previous slide. So there's lots of guidance available in the literature so that you're selecting strategies that are known to be impactful to address known barriers and facilitators to change. Once an intervention is implemented, it's important to understand if it's improved patient outcomes, has it improved health system outcomes, but it's also really important to understand how did it work. And so implementation outcomes, which are listed at the bottom of this slide, they are different than patient and health system outcomes. When we're examining implementation, we're looking at things like, is the intervention acceptable? Was it adopted? How feasible is it to be used? And so Proctor's taxonomy of implementation outcomes describes 8 different types of outcomes and how those can be considered in your evaluation of the implementation process. Also important to start to consider about some learning health system outcomes if that's the area that you're focused on. So this learning health system logic model lists 9 different types of learning health system outcomes like population health, the care experience, did it impact cost of care, as well as equity. These are really useful starting points for learning health system implementation research and also offers a practical guide to many of us on this call that are trying to build and operationalize and evaluate learning health system initiatives. So a key takeaway from those last few slides and some of this outcomes work is that there's a difference between impact and implementation outcomes, but it's so important that we're examining both types of outcomes. So looking at the impact on patient health, the organization, as well as the health system, as well as that process of implementation. So a quick overview of implementation science principles, but it really leads me to this summary slide of some of our work in the field. And we're looking at implementation strategies. And traditionally, implementation science literature really has centered those strategies on the individual within a health system context and hasn't really had that system level focus. And so we've seen this firsthand in 2 of our knowledge syntheses works, as well as a multi-method qualitative study where we looked at implementation and sustainability strategies. And so from this work, we know that multi-level adaptable strategies are really needed to support that organizational level change. And this led us to an opportunity to build on what we've learned in the implementation science literature to understand, can we use that to support learning health system implementation? And that's where Mari's work comes in. So over to you, Mari.
Great. Thank you, Christine, and thank you, Walter, for the introduction. So despite the definition of learning health systems first being coined about 20 years ago, we still don't have a great understanding of how this is operationalized in practice. So to address this gap, part of my health system impact fellowship work, along with Christine and others, was to conduct a systematic review exploring the implementation and evaluation of learning health systems. And we were interested in any papers that define themselves as a learning health system and that discussed the implementation approach they use. So we looked at any country and any healthcare setting, and we extracted data related to reported implementation strategies, outcomes, and learning health system characteristics. So we identified over 5,000 studies in our search and included 35 papers which reported on 31 different learning health systems. Most of the studies were from the US and were published quite recently, so between 2019 and 2022. So this highlights just how much interest there is in learning health systems and how rapidly this field is growing. In our review, we used the table that Christine had mentioned, so John Levis and colleagues' list of 7 learning health system characteristics to understand what features of a learning health system were being reported most often, and whether any studies actually met all 7 of those criteria or characteristics of a learning health system. We found that no studies in our review reported on all 7 features of a learning health system, and some features were reported more often than others. So digital data capture was the most common feature that we identified, while patient engagement and a culture of rapid learning and improvement were reported least often. This finding wasn't overly surprising to us, as there is a strong emphasis on health systems to build a strong digital foundation, to have electronic databases and health admin data in order to rapidly improve practice. However, we would argue that some of those other features, such as patient engagement, are maybe more important when trying to improve health systems and to achieve the quintuple aim. And although we didn't use the Learning Health System Action Framework or the Learning Health System Engine in our review, I did want to just put this in the context of those 5 gears from the Learning Health System Engine. And so if we had mapped what we pulled from the studies related to learning health system characteristics to those 5 gears, it might look something like this. So gear 1, which is analytics and population insights, would probably have been captured most often, while gear 3 and gear 5 might not have been identified as often. We also use the ERIC taxonomy of 73 implementation strategies to extract and map the strategies reported across studies. A total of 33 different implementation strategies were identified in our analysis. And again, we saw some patterns where certain strategies were reported more often than others. So changing record systems was reported most often, and this strategy came up 20 times. And just to put that in context, the next most frequently reported strategy came up 7 times. And some strategies were only reported once. Many strategies of the 73 available options were not reported at all. And again, we were seeing a similar pattern where there seems to be a focus on the data piece. So for example, changing record systems was often related to changing health admin data collection or adding something in their electronic health record system, while including patient and family feedback doesn't seem to be as much of a focus across the learning health system studies that we included in our review. We used Tierney's list of 10 implementation outcome measures to understand how these learning health systems were being implemented and what measures they were assessing. We found that intervention complexity and adoption were the ones that were reported most often. And we also looked at learning health system outcomes as described by Alan and colleagues' logic model, which Christine had also mentioned. And we found systematic adoption of evidence-based practices was reported most often. So that was reported 17 times, along with knowledge to action latency and population health. And then we also characterized outcomes using the quadruple aim. So looking at patient-related outcomes, provider-related outcomes, population health outcomes, and cost. And we found most studies reported on patient-related outcomes, so things like reduced length of stay or improved time to diagnosis, as well as population health outcomes. And I did want to note here that we didn't look specifically at equity, and we didn't use the quintuple aim in this part of our synthesis. But this was one of our key takeaways, was that there overall was a lack of emphasis on equity across the learning health system papers that we included. So some of the key takeaways from our review included that clearly learning health systems research is a growing field. There's value in advancing the science on learning health systems, particularly around evaluation. And it was clear from our review that there are few examples of fully operationalized learning health systems, at least at the time of publication. And I think a lot of researchers and organizations are still striving to meet that comprehensive learning health system vision or model. And there's a strong emphasis on data and digital infrastructure, but less on patient engagement, co-design, and fostering a culture of learning. So I think this is an area that we should really be focusing on as the future of learning health systems research. And many studies in our review did report positive outcomes, which is promising. But I think we still have a long way to go in understanding what a successful learning health system looks like. And implementation science can be really helpful in this regard because it forces researchers to consider other outcomes and aspects of moving towards a learning health system that can help ensure that it's sustainable over time. And so I'm now going to walk through an example of a learning health system which we included in our review, and I'm just going to show how we extracted implementation strategies and outcome data during our analysis. So this will help give you a better idea when everyone goes into their breakout rooms and starts to think about this in their own health system context. So the study that I'm sharing is a learning health system called Learn from Every Patient. And we actually included 2 papers that reported on this learning health system in our review. And this particular learning health system was at the clinic level. So it was an interdisciplinary cerebral palsy clinic for children within a larger hospital in the United States. Clinicians and researchers wanted to examine some of their practices within the clinic. So specifically, they were concerned that they were conducting unnecessary screens and x-rays on some of their patients because their usual practice was to screen every child and give everyone an annual hip x-ray regardless of where they fell on the gross motor functional classification level. And so clinicians wanted to know whether they could still see positive patient outcomes if they stopped performing this practice with children who were considered to have mild cerebral palsy based on this classification system. And I just want to note here that this particular learning health system, as an example, was done at the clinic level within a larger healthcare organization. So some of you might be working at that clinic level, others might be at a broader organization or health system level. And that is okay because a learning health system can be implemented at any of these levels of our healthcare system. So when we analyzed the information in these 2 papers that reported on the Learn from Every Patient learning health system, we found that they met 3 of the 7 characteristics for learning health systems based on that list that John Lavis and colleagues had come up with. So they met the criteria for digital data capture, timely production of research evidence, and appropriate decision supports. And so under each characteristic, I've included a summarized extraction from the papers just so you can get a sense of how we had synthesized the data and mapped it to those 7 learning health system characteristics. And then for this presentation, I also just added in the gear that would align with that learning health system characteristic, just to bring it back to that learning health system engine that some of you might be more familiar with. And when looking at learning health system strengths and opportunities, the Learn from Every Patient study met some of the learning health system criteria, but they missed others. So as you can see, they had a strong focus on data, Their main priority was to use the electronic health record system to change practice and try to integrate evidence into their daily clinical practice, but they didn't meet all the learning health system criteria. And as was a theme across our review, there was little focus on incorporating patient voices into their practice change. So as a researcher, I would be interested to know whether they had thought about asking patients their preference on that practice of annual x-rays and how they actually incorporated this into their decision to change that practice. It would also be helpful to kind of probe this team on their implementation plan and understanding how they would ensure this practice change would be adopted by everyone or sustained over time. When synthesizing the data and using the ERIC taxonomy of implementation strategies, we identified two strategies used in this particular learning health system. So they conducted local consensus meetings and changed record systems. And this is an excerpt from the paper where they discussed creating documentation templates in the electronic health record. And so this was an example of text that led us to tag this as change record systems as an implementation strategy that they used. And again, when synthesizing each paper and determining what implementation measures and learning health system outcomes were reported, we looked at the text and tagged sections of it using the list of implementation measures. So this study was tagged as measuring feasibility and implementation cost. And this is an example of the text. We tagged it as feasibility as they were talking about clinicians making this practice change faster and easier. And similarly, this is an example of a section of the text from papers we identified as care experience as a learning health system outcome. And you can see this study didn't report on every learning health system outcome or implementation measure based on those taxonomies we were using, but they did include some. And then this study also reported a few different positive outcomes after making their change to their practice, and this included decreased inpatient days, decreased inpatient admissions, decreased urgent care visits, and lowered healthcare costs. So we categorize these outcomes as being patient-related and cost-related outcomes based on the quadruple aim. And so in summary, this particular example of a learning health system met several characteristics of a learning health system, but not all. They also used several implementation measures to change practice and reported several positive outcomes. However, you can see how there are some gaps in this learning health system. And if I were an implementation scientist or a health system scientist working with their team, I would want to get them to think a bit more about the patient voice in their work and to look at some other implementation strategies and outcomes to ensure the longevity of this practice change.
Okay, great. Thank you so much, Mari. So taking from what we know about implementation science, those principles and methods, and what Mari has described in our review and that example of applying it to the Learn from Every Patient learning health system, we want to build on all of that and try to apply some of those principles to the learning health system lens. So the goal for the breakout groups is 5 different pieces. So in our smaller groups, we'll ask everybody to think about a practice change within your context, within your health system context, and briefly discuss that with the group and really choose one that you're going to individually work on through this activity. From there, we'll ask you to think about some of those barriers and facilitators to using a learning health system approach, using the learning health system engine, as well as the consolidated framework for implementation research. So thinking about some of those barriers and facilitators to using the different components of a learning health system to support the practice change. Next step, we'll be building on that and mapping it onto selecting some implementation strategies using the ERIC taxonomy. And again, those are strategies to help support using this learning health system approach. And then 4th step is to think about those outcomes. So thinking about patient, provider, system, implementation, learning health system outcomes for your context. And then at the end, we'll ask that you have a brief discussion and prepare for reporting back and reflections and discussion as a larger group. Before we get into that, any just questions about the breakout activity? We'll have lots of time at the end for more general questions and comments and discussion, but I thought I would pause here before we move.
I'll just step in to say thank you for an expert summary and a masterclass in implementation in so like about 20 minutes or so, putting together
Thanks.
so many different elements and I think in a very, very sensible way. So thank you very much. I think we're well set to think about this in the next step.
Great. Thanks, Walter. Yeah, you're right. It's a bit of a crash course, lots to further discuss. Okay, great. Welcome back, everybody. I hope you enjoyed the conversations in each of the breakout groups. Our goal for the next 30 minutes now really is to just reflect and generate some discussion. Open to the group. If there's any breakout room that would like to start by sharing some key takeaways or lingering questions that remained. Yeah, this is meant to just be a really informal discussion. So I'll open it up first. Andrea.
I always like to get the share back over with when I'm the nominated person. So here I am. I did too much
Amazing.
talking in our room, so I was nominated as the person to share back. What we decided to do was focus on kind of a common challenge faced across different organizations, which was implementing screening practices or new screening practices within these different organizations. So we had many different implementation barriers and facilitators identified, including, challenges of getting buy-in. And so some of our strategies addressed that, including the opportunity to identify early adopters who could kind of champion pieces of the screening strategy within their organizations and be kind of a bit of an informal like advisory, I suppose, on issues doing so. And then in terms of what that would look like if that went well and we were able to kind of successfully implement the screening, it would be, I think one of the key things is that it would be acceptable to both providers and patients because screening can be burdensome on both ends. And so acceptability seemed like a really important implementation outcome because it would probably lead to longer term kind of maintenance and sustainability.
Thank you so much for sharing. Really interesting to hear that there was kind of those common challenges around an existing practice change within several different organizations. So any other group want to build on that? I do have thoughts, but I want to first open it up. I can maybe anyone from my room want to add to that. I was just thinking a lot about the buy-in piece, and we talked a lot about the importance of the relational type strategies and how that's much harder, but needed to address some of those leadership type barriers. Vicky, thank you, Vicky.
Okay. Yeah, so we also kind of had similar challenges in the examples that we were talking about. And kind of of our biggest barrier wasn't getting the data, but kind of getting initial buy-in to do our project, and then kind of moving the project along afterwards. And so we talked a lot about kind of culture, buy-in, as well as trust and getting kind of the initial building trust to be able to carry on the project. And we also talked a little bit about sustainability and how you get the department to move forward even if we're not there. So those are some of the themes that we talked about on our side too.
That's a great summary. Thanks, Vicky. Any other group like to share a little bit about their key takeaways from their discussion?
Is there anyone from, oh, there's Sam.
Sam.
Sure, I can share back. And Laura, Prosy, and Celine, please do interject if I forget anything. But I think the thing that we gravitated towards were the barriers that we face at our respective organizations. One of the main ones we discussed was that issue of culture. How do you instill a culture of learning within organizations? And I think we had some good discussion about in a health system, how do you build a culture of evaluation and actually taking those evaluations and learning from them, whatever that means. From an NGO perspective, Salim shared with the Red Cross, the going from emergency to emergency without necessarily taking time to reflect on what was done. Even the biggest emergency of our time, COVID-19, there was questions about what was actually changed because of that. And did we learn anything from COVID-19 for the next pandemic, whenever that does happen? And I think Prosy shared some great insight about, and this builds on Vicky's point, building relationships and trying to foster that sense of trust with people at the outset of evaluations and research to ensure that, whatever your findings are, there is some uptake at the end of the process.
Great. Mari, I feel like a lot of these relate to your review findings in terms of data being the focus, but not a lot, and a lot more barriers related to some more of those, the culture of learning and engagement piece.
Yeah, and I was gonna give my group an opportunity to maybe step in, but I was the nominated report back for our group. And so I can also summarize sort of what we talked about, and it's a lot of these similar themes around the culture and the buy-in, and also we had a lot of discussions around sort of like we're a lot of us are taught to think of like that health system, that really macro level health system, but there's a lot that we can do at that practice change level too. But it's all really complicated and hard when we're working in these health systems, and funding comes and goes. And we just talked a lot about the challenges of trying to accomplish this learning health system vision. And yeah, a lot to do about the culture and just yeah, lots of different team members and clinicians, and trying to get everyone on board and kind of adopt that idea of learning and a learning health system.
Victor.
Yes.
Oh, you're on mute.
Sorry about that. Can you hear me now?
Yes.
Our group focused our discussions on that last year of the LHS framework, so the importance of providing feedback. And we used the Ontario Health Team's context to frame some of our discussions, and really talked about the importance of making sure that there's a fit between the performance, the data you provide to recipients and their workflows, their capacity, their capabilities, their competing demands, and being proactive about continuously improving how that feedback is provided, because that's ultimately what we want to, that'll drive change, right? And so if that feedback doesn't resonate with the recipients or not, it's not useful, then all of the prior years they end up not functioning as well. So we talked about having the right data, the right level of data, and understanding barriers and facilitators to the use of data within their regular workflows, and understanding all the competing demands that leaders and providers have, and really trying to understand how do we provide that feedback piece in a way that is actionable, feasible, and easy to use, and so forth, to facilitate change.
Thank you.
Yeah. I think it speaks to, and I'm curious what the group thinks, and maybe in your own context, why sometimes does digital transformation, not saying that it's easy by any means, but why that is more of a focus in learning health systems than some of this other kind of governance, culture change piece. Walter, either thoughts on that or something else?
Yeah, no, I think actually the thoughts on, I was just reflecting on the comments back, and even during your talk, I was thinking as you were summarizing the available evidence mostly around data, people are looking for technical solutions to technical challenges, right? Like these are, and that's that, yeah, the technical fix seems like a solvable, it might be complicated, but it's not complex.
Right.
Um, and there could be a set of steps. And I was listening, as people were talking about their feedback from their groups, hearing about, buy-in, trust, reflection, culture, um, and and I was thinking parallel between implementation and I think the way I think about a learning health system is it's actually not the thing to do, it's the way of doing things.
Mm-hmm.
And people will look at it like, what's the thing I can do?
Mm-hmm.
Um,
And check off that it's been done.
yeah, and
Yeah.
there's evidence. We installed the system. No one's using it, but we installed the system, right? As opposed to the way getting that behavior change, that way of doing things, and we've actually had some reflections lately amongst our team. We're looking at actually a problem of physician involvement in integrated care, and there are lots of structural issues. And we actually had used CFIR to conceptualize the review of what the practices were, and then we're actually thinking between like what the best framework would be for looking at recommendations for how to do things better, and you know. The things that are more individual, I think you kind of covered this off if people are, paying attention, or at least I caught it, that things like COM-B, like they're really behavioral, right? And they're individual and behavioral. And things like CFIR and some of the other bits, they're more about like, we have the outcomes we get because we created a system that drives those outcomes. And it allows us to pay a bit more attention to the structures and processes, like our way of doing things, and not just about the individuals. And I think it's really important to pay attention to those more, which will be adaptive changes in the way people interact and do their work.
Mm-hmm. And yeah, I think just building on that, some interesting comments in the chat, those technical digital solutions feel tangible. It's like it goes back to the thing, right? Trying to implement the thing, whereas culture change harder to grasp. And yeah, Jillian, harder to advocate for culture change without data. So it's also within a cycle.
Yeah, I think
Any?
one bit that we might pay a little bit of attention is like, are there markers of the way processes are implemented, right? So if we take that implementation science, like, are there things that we can actually think about measuring? And I think you talked a little bit about this, you and Mari, about how to look at implementation outcomes and mark some of those.
Mm-hmm.
Yeah.
And see value in those, right?
Mm-hmm. Christine?
I have a question, kind of half-baked, so apologies, but I wonder, the vision for a learning health system is this kind of big, gorgeous vision of a whole system that is working together super effectively for this slew of outcomes that we hope to achieve. But that's really hard for a lot of people on an individual level to grasp and see themselves in. And as Walter is just kind of saying, change happens at the level of individuals' behaviors. So we really do need individuals to buy in and change how they're operating on a personal level to then see that systems level change. So I'm wondering if you have any insight or advice on how to balance, pushing for that individual change while not overwhelming people with the whole vision of a learning health system and kind of easing them in. I don't know if I'm wording that right, but that balance between individual change and not losing sight of the whole vision, but also not overwhelming people with the whole vision.
Mari, do you have thoughts?
Yeah, I think that's something I keep coming back to in this work is, even some of the papers in our review, like some were, calling themselves a learning health network, and they included multiple clinics or organizations, and others were at this clinic level, like the one that I had presented. And it's so hard because it can be done at any level, I guess, but I think, yeah, it's just we're still not really seeing, like I even don't know if I have an idea of what like a successful learning health system is or how it could look. But I do think that starting at that smaller level is sometimes easier to manage and just working towards, like those gears or those characteristics of a learning health system. To me, that's what I kind of, those are my benchmarks. It's like, okay, are we engaging patients in this process? Yes, we have the data piece, but we don't have patients, and okay, the culture is a huge gap. Like, what are we going to do to address that? And just in a small clinic team, kind of work towards that. And then implementation science can be pulled in to help us scale and spread that. But yeah, I don't know if I actually answered your question, Christine, but those are just like my thoughts on, yeah. I don't know if Christine,
There
Cassidy.
may not be an answer to my question.
Yeah, I'm really curious what Shelley and Walter think about this, and then I can add at the end if there's any additional insights. But Shelley, over to you.
Yeah, thanks. Great question, Christine. And it just brings to mind one of the conversations that I was in recently. As some people on the call may know, Dr. Marissa Bird, who is a current HSIF ECR fellow, and Dr. Carly Whitmore from McMaster, and I co-lead the Learning Health Hub, which is a learning health system network. And in this network, we have three different working groups, and Marissa leads the Enabling Environments working group. So, kind of exactly on theme with the discussion that we're having right now, like how do we actually enable a learning health system? And one of the things that was being talked about in her most recent meeting was just the demand for like role descriptions and a governance structure that really does lift a learning health system across, the clinical frontline, operational staff, people working in data and performance analytics, and then also leadership, researchers, trainees, et cetera, and how they all kind of, work independently, work together, what the role kind of looks like, that accounts for, not only your regular duties or the traditional duties of each of one of those roles, but also then, what's not added in like a side of the desk type of way, but what is the expectation and what is the role and culture and sort of additional competencies that each one of those people takes on to then drive the learning health system forward. And it really does take like such a socialization, I think. Like I've been in meetings where an operational leader will say, hey, team, like you're not used to this language, but we are a learning health system and this is how we do things. And I think that really kind of goes a long way to kind of take on this brand and then also kind of really socialize. It's not just those people over there, it's all of us, and we all have a role and a stake in this. Curious to hear your thoughts though, Walter.
Yeah, those are excellent observations. I mean, I'm really enjoying this discussion and learning. I think we kind of, have had a couple of opportunities to use a learning health system model to implement local QI or program implementations and changes. And so I think like not so much at the individual level, but at the team level, as teams are, probably relates a little bit to the comment just now from Vicky around like you're working with a team, they're going to implement a change. How do we actually think about this? And I've done this at, within an organization. So we did this at, Trillium Health Partners in the hip fracture, building a new pathway for that. But I've also done this across programs. Another one model was a transitional care program funded by the Ministry of Health across 6 teams on, they called it bundled care or integrated funding models. And they were a little like much more at scale. Like one of the team was like, I don't know, 3,000 patients. And so they were at that kind of scale that they were moving the transition of people from a hospital to a community setting through a high volume program. And, it's about in that project, like for each of them, what's the data you have to understand the problem you're trying to solve? What are the practices you're putting in place? What's the evidence behind them? Like at that granular level, how have you thought about co-design? What's the co-design you're doing? What are your implementation practices? What kind of coaching do we need to help you get that implementation? We actually had coaches um, involved. Like when you get to implementation, you need coaches. Like that's one of the things I've probably possibly learned. And then, our job on the work was more around the evaluation and rapid feedback. And so we're giving people feedback like at least every 3 months and even more rapid. And, Gemma was actually the work doing a lot of the ongoing feedback and newsletters and sharing, communicating back to the teams how the progress was happening in that fracture project. And that the communications bit. And so that's at the project level, and you're thinking at the scale and the approach. And then I think, what happens when we move to systems is that's a very expensive process at a project level. Everything I just talked about, like that's a resource, very intensive bit. And the thing that becomes more efficient as you scale up is you can start building in the infrastructures. So that you have like data science teams that are ready and able to do some of the things more automatic, that you have built-in systems that enable you to do more rapid cycle. Like for those projects, like the 6 integrated funding models, we had to build a complete data system into each of the projects to feed up on both process and outcomes. So because we were interested in intervention fidelity and knowing like, is the thing you're doing actually going to have the outcome you expected? And if you don't, is it because you didn't do the thing or because the thing didn't work? Um, and so that's where I think, it's pretty expensive to do that project by project. And if you're committed, then you figure out what are the essential elements and use those projects to build the system capabilities that have sustainability.
It's a really good point that it's, individuals within a system, but they're working within this infrastructure that either does or doesn't exist. Any other, I'm keeping an eye on the time. Any other takeaways that anyone would like to share before we wrap things up? Well, I think lots of food for thought and access to some of the resources in that worksheet. Feel free to take that and reflect on it and apply it to different practice changes perhaps that you're working on. Hopefully it will be useful to you. I'm maybe going to ask, is it Gemma or Christine going to share an evaluation in the chat? So keep an eye out for that. Thank you, Gemma.
Give people time to go click into there to make sure they get it. Because we're building this, but how the conversations go, the ways we can actually do this best, like what's our time proportion share about talking, workshopping, coming back together. I think we're trying to do a little bit of all of these today. I want to just great thanks again to Christine and Mari for creating the material for this. And I know you're experts in this and you have much of it handy, but it takes time, and I just really appreciate it. I just want to say how much it is. And I think we actually now have a video resource of 10, your talk, and it's where everybody is going to be our primer for how to understand the vast literature of implementation science in a bit of an overview before people kind of go really dive in to know what they're trying to understand. But I think the conceptual bit taking us right from conceptualizing implementation through CIFR, right through to how to understand ERIC and strategies, like how they fit together. So thank you very much for putting that together. Great gratitude on behalf of all of the program.
Thanks again.